Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
In this episode of the Pod of Inquiry, I spend some time discussing a case that's very interesting in what will be our first case study illustration, number one, and hopefully we'll have a few more of these types of episodes because I think they're really illustrative of other considerations that may not be the primary consideration in some of your case management. This study focuses on sural nerve entrapment, anatomical variations of the sural nerve, and different ways to think about conditions that may not respond to the usual treatment after the usual diagnosis. So I hope you enjoy this episode. The video can be seen on thepodofinquiry.com. It's a very difficult episode to just listen to with audio only because the pictures really illustrate this nerve entrapment. So I would recommend that you go to the video if you have any interest in this. I'm here with my nerve fellow, Dr. Artinder Nagra, and we're going to present the first case study illustration for the Pod of Inquiry. We hope to be doing many more of these. She was presenting this last week or the week before. I lose track of time at the Association of Extremity Nerve Surgeons. It was one of my patients that she put the presentation together. You'll be able to get this presentation on our YouTube channel. You can go to thepodofinquiry.com off of our website, and it will be there. I apologize to the folks who are just listening to it via audio, and encourage you to get the most out of it and see these great photos that we would recommend that you actually look at it on video format. So, Dr. Nagra, thanks for coming up to Jasper today.
No problem. I'm happy to be here.
All right. Well, why don't you tell us about this case study?
So this was a patient, middle-aged patient that originally came into clinic with complaining of pain behind her lateral malleolus and at the fifth metatarsal base. She doesn't have any significant past medical history, no significant trauma, but one day she comes in complaining of pain, and we conducted an ultrasound that showed minor peroneal tendinopathy. And so our first instinct was that the trajectory of the peroneal tendons are exactly where she's complaining of the pain. And so, of course, our first instinct was to inspect the peroneal tendons and see if the etiology stems from them.
So that would be a natural assumption, would it not, for almost anybody in the foot and ankle universe when somebody comes in and they think about, okay, this patient's presenting with pain at the styloid process of the fifth metatarsal, that it's undoubtedly got to be peroneus brevis pathology as its etiology.
Absolutely. Especially a lot of patients, people don't know when they have lateral ankle injuries. People don't even realize it half the time, and they may not remember what may have caused the injury. Especially females, depending on the type of shoe gear that they wear, they may not realize that they are susceptible to peroneal tendon injuries. It's sometimes thought of as just a trauma or purely to athletes. So, of course, when she presented, we automatically think that absolutely, just because that she was complaining of pain at the fifth metatarsal base, especially at the insertion, that's where the peroneus brevis inserts, automatically you think of a tendinopathy.
And she did have evidence on ultrasound of some signal interruptions. So she did not have a normal echogenic pattern to her ultrasound. So go ahead. What else?
Sure. So after we did the ultrasound, as mentioned, it showed peroneal tendinopathy. And so we went ahead and treated it with a peptide injection, as we don't commonly treat tendons with a steroid injection, as it can be harmful to the tendon itself. And peptides have shown to have regenerative properties. And we commonly in the office use BPC-157. We've used it for plantar fasciopathy, and we use it for tendinopathies as well. And of course, this case was no different in that we used it for her peroneal tendinopathy. And she was continuing to show in the subsequent visits some relief, especially behind the lateral malleolus. But she still had this lingering pain at the base of the fifth metatarsal and along it. And so at that point, you kind of rule out the peroneus longus, and now you're still thinking that it's a peroneus brevis tendinopathy if it's at the insertion, because, of course, we automatically think that's the only thing that's a big anatomical structure at that area.
Right. Yeah, and I recall this patient. I recall the history very well, and she did get a little bit of improvement, but we've had such great experiences with, intralesional intervention with BPC-157, and rarely do we get a failure if it is just a musculoskeletal issue. I mean, the peptide works extremely well. So when you see a failure like this, it's outside of the norm of what you would expect to see, and so she continues to go down the path and continues to complain with things. And so go ahead and finish up with, her presenting case.
Sure. So I believe then our next step was to order an MRI and make sure that we're not missing any underlying pathology. And nothing came out particularly too remarkable on the MRI, if I remember correctly.
Right.
And so at this point, we're kind of running out of options other than to take her to surgery and see what is actually going on, because as we all know, sometimes a lot of these things don't show up on MRI. I think you can ask a lot of surgeons that when there's a peroneal tendon issue, they take them to surgery, there was a tear there or an interruption, and it was never detected on MRI. So of course things can go missed, and our next instinct was to take this patient to surgery and see what exactly was the problem.
Well, she actually begged me to take her to surgery, and it was real interesting because I remember, and we'll see how this correlates when we get the other pictures up on the screen, but she described this pain as being not only at the styloid process, but also coming up over the calcaneal cuboid articulation, the fifth metatarsal base cuneiform, cuboid articulation, and then also even having some pain distally radiating around the lateral plantar surface. So it was a really unusual presentation. And she just said, listen, I don't really care what you do, but you have to open this up and look at it because there's something wrong. And now I had operated on this patient several times before for other conditions, and I felt that she was a very good historian and that, she accurately related what we did find in those previous surgeries, and she recovered well from the other surgeries. So it was one of these situations where I had a little bit of an advantage because I kind of knew where she was coming from. I had a good rapport with her. And when she said, listen, there's just something really definitively wrong in that area, just take a look at it. I'm willing to sign anything, to give you permission to do that. So that's indeed what we did. Now, I just want to interject a little comment on MRI, because usually in these cases, MRI is far more inferior than a good ultrasound. And just for tendinopathy, there's so much that's missed on MRIs. So sometimes in these types of situations, the MRI is more of to show what's not there rather than to hope and get something that it says, oh yeah, this is it. So.
And actually, I wanted to ask you to follow up on that. Number one, had you seen a similar presentation to this before? most of the time when patients presented with something like this, had it in fact been peroneal.
Yeah,
injury.
no, I mean, that was the thing. That was the whole conundrum because, obviously that many years in practice, it's just routine to think and go down the tendinopathy trail and the insertional part of the peroneus brevis. So it was one of those things where it was just tendon de facto because we see this so commonly. But then you have to think, and that's the power of this case study, because there are those patients that have a different etiology and they don't get better with your standard treatments. And then you start scratching your hair out. And then when you do see the real pathology, it's very understandable. So it's one of those things where you can have perfect 20/20 retrospection. But when you're working these up, it's just standard that, hey, we're going to really just think about insertional tendinopathy of the peroneus brevis. So that's really what makes this such a powerful case illustration. So let's go ahead and see some more.
Sure. So we took her to surgery in November of 2020. And on the next slide, this is what we had seen. So the very first picture going from left to right, my left to right, is of the tenotomy scissors pointing to what appears to be an adhered sural nerve to its surrounding structures. So you can see that you can't even differentiate the nerve in this first picture. It almost looks like it's a part of the fascia, or it looks almost adhesed. Probably it almost looks collagenous, fibrosed. And then in the next picture, and in the subsequent picture, you see that we try to isolate it from its adhered point. And so the purpose of these images is just to show you that if you're not careful, you might miss this as seeing that the nerve was adhered, but you have to be aware of the anatomy at this level of the foot, because the sural nerve is very variable anatomically once it passes into the foot. And so you have to be on the lookout for not only the nerve, but its branches.
And that's why we want to use microscopic loop technique and blunt dissection in this area, because you can blow through a nerve before you even know it.
Absolutely.
So
absolutely. And of course, utilizing the loops and making sure to, as you mentioned, atraumatic technique, making sure to directly not touch the nerve, as you can see in the last picture here, which we did not do.
Yeah, and why you have that picture up, you have to be really kind of careful when you're using these vessel loops, because it does help you tremendously, because now we're able to, one of the tenets of nerve surgery is you always go from known to unknown. All right. So we can work down it. Sometimes we have to start distally and work proximally, but in this case, we've isolated it. We've put the vessel loop on it, and we're very gently tugging on this. So I see some people really pulling on these hard. You have to really be careful with that. All right. So let's go ahead and see the next photos.
So these are some more photos. So this is as we begin to free the nerve from its adhesion point. So in the first picture here, you can see that the vessel loop on the most distal end, and you could see the vessel loop on the most proximal end, showcasing that we're slowly lifting the nerve off its adherence point. In the previous pictures, you couldn't even see where the nerve started and where it ended. And now, looking into the second picture, you can actually start seeing how much it's branching. Actually, it's not just one nerve. You could see up to the third picture that now we have 3 vessel loops all around the nerve, and it's branching quite significantly. And so you have to be careful not to, I believe, just
avulse it.
Exactly.
Right. Now, what's real interesting in this middle picture here, look at the branching pattern on this sural nerve. Okay, so we're proximal here, and then you see this little branch coming right off, and this is the branch that's coming right up to the dorsal aspect of the 5th met cuboid articulation, and this was exactly where she said she would get pain sometimes. Most of it was really more at the 5th metatarsal base, but then she also said she had pain that would go down plantarly, and you can see this is a plantar branch coming off of the sural, and then the main sural's continuing distally right up here. So it fits, this nerve pattern fits exactly what she was complaining of in her HPI. And it's amazing how anatomically accurate these people are when they're describing these clinical nerve entrapments.
Right, and it goes back to the saying where you have to try to listen to your patients. Sometimes we think that what they're complaining about doesn't necessarily match up with our diagnosis, and I think that this illustrates there's proof into where they're complaining about the pain. We just have to be aware of our anatomy. And another thing is, as you can agree, that sometimes the branches of the lateral plantar nerve, you can easily mistake. When she was complaining of pain plantarly, I'm sure someone might easily mistake it for possibly a lateral plantar deviation, but you can clearly see it's the sural.
Yeah, and that's a great comment. I'm glad you brought that up, because we like to try to put everything nice and tidy into these anatomical conceptions that we have from all of the anatomy books, but rarely does that hold true. And I think the sural nerve has a lot more plantar innervation than a lot of people appreciate. And in this type of case, and we've had many others, you'll take care of maybe what you think is a lateral plantar nerve injury, but then they still have pain, and that's because they have some component coming from somewhere else. And usually if it's a continuation of pain after you've addressed the lateral plantar nerve, then you have to start thinking of sural nerve right away. And the nice thing about, working these patients up with diagnostic lidocaine injections, you're able to kind of ferret that out. So in this case, this patient did extremely well with a peripheral nerve block of the sural nerve, but we blocked it proximal up by the lateral malleolus. And so that really doesn't tell you a tremendous amount about the branching pattern, except when you take what the patient has told you where they feel their symptoms, which may not fit into your conception of where the sural nerve should really be running. But then after they have that diagnostic block, then that pain goes away. Well, then you can kind of feel a little bit more comfortable. Now, if we wouldn't have gotten that result with the diagnostic block, then we would have to think, okay, let's do something with the lateral plantar nerve, come over there and see if we can knock it out. And that would give us some more diagnostic information prior to going into this. Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals, and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantcellars.com. That is CEVANT sellers.com. Spelunk15.
You bring up a good point about diagnostic blocks. So in any type of nerve pathology, of course, you recommend doing a diagnostic block to pinpoint. The whole purpose is to pinpoint which exactly nerve it is. And you had mentioned blocking proximally versus distally. Can you comment on the importance, even with other nerves, differentiating? How do you differentiate with a diagnostic block one nerve versus the other, and what's the best location for each nerve?
It's a great question, and that's a concept that's super important for anybody that wants to deal with peripheral nerve pathology. Now, let's say, this is a great example, but let's say the patient had pain here, and maybe they had a peroneal tendon repair, and they're complaining of a painful scar. All right. Now, if we put local anesthetic in right here, it's going to make that patient feel better. But it doesn't tell us anything as far as specificity of where this pain generator is emanating, which nerve branch is really involved. And so this could be, for example, there could be a branch from the superficial perineal nerve, which happens very frequently, coming down into this area. And if you blocked right here, it's not going to give you any differentiation. That's why when you do these blocks, you always have to go up north or proximal to where your site of compression or your site of injury is, because if you inject a painful scar, great, it tells you that they get better, but it doesn't tell you which wire you have to work up. Great example of this is hallux valgus, right? So somebody comes in, they've had a nice bunionectomy and everything looks great on x-ray, the sesamoid position's fine, but this patient just has a tremendous amount of pain inside the scar. And, clinicians will call me and they'll say, yeah, they blocked the scar and it makes all their pain go away. So they know it's not an intra-articular pain generator, but that doesn't tell us anything. Okay. So is that coming from deep perineal nerve? Is it coming from superficial perineal nerve? Is it coming from saphenous? So that's why you have to come up north into the calf or anterior aspect of the leg. If you're looking at, the saphenous, for example, and that way you'll be able to measure it out. So that's a great point, and that's something that conceptually is like the most fundamental thing, because you're not going to glean any information when you block distally at the level of the scar.
Absolutely. And my next point is, I believe that in this case, we had just decompressed the nerve, correct?
Correct. There was nothing done tendinopathy-wise.
Tendinopathy-wise. So hypothetically speaking, I'm sure that people may encounter a different scenario in which maybe decompression might not be enough. So what could be some possible, let's say if there was a neuroma in situ here,
right,
what could be a possible treatment option that way?
Well, if there was some type of a neuroma, in continuity or at that spot, you'd have to go back to the history and what did this patient, did they have a contusion? Did they have something that was a frank nerve injury? Did they have a failed perineal brevis repair before? I mean, those are things that, you have to glean from the history. So all these nerve cases are really like crime scenes, and you have to go and you have to pick up every little tidbit that's around this crime scene, to try to figure it out. And so if they say, all right, I got slammed by a baseball bat in that area. Well, now you have to think, well, we may have a neuroma in continuity, and that's going to be a problem. So if we have a neuroma in continuity, then we have to decide, well, what do we do for it? And the answer is, well, you can denervate it. You can, potentially do a nerve transfer. You could avulse the nerve and try to wrap it in that area if you felt that it was just a small branch coming off of it. I don't recommend avulsion, except in very, very tiny branches where there's nowhere else to go. But that would be a different scenario. And in those types of situations, you probably want a peripheral nerve surgeon to handle that, because you could get into, anytime you denervate something, you always go into a more dangerous neighborhood for sure. But that's a great question. Now, intraoperatively, I knew this was her pain generator just based on what we see on these photos. I mean, experientially, if they have this type of an entrapment, they clearly could, they're clearly very likely going to get better after nerve decompression and neurolysis. And then we're also able to inspect the nerve once we remove the sites of entrapment, and we can see that there's no internal damage to the nerve. So, but I think, just taking a pause to look at this picture again, I mean, you can see in this area how, with the number of branches and how tethered down it was, and there's not a lot of subcutaneous fat to really protect this. You could see this nerve getting pretty easily damaged. I mean, it could get damaged by just very tight footwear or maybe very slight inversion injuries. I mean, it doesn't take a lot for a nerve to get hurt.
Absolutely. And I think that's a good point that you mentioned, and that this nerve is quite superficial because of not a lot of subcutaneous fat being present there. So it makes sense because its trajectory is along with the peroneus brevis tendon. I think this case tells us that we have to be on the lookout for sural pathology when we're in this region because of the nature of it being so superficial.
Right. And you can see, from these photos how easily it is for someone to damage this nerve when they're doing let's say a Jones fracture repair. I mean, it'd be pretty hard not to hurt that nerve.
Right.
With just, repairing your fracture. So it's an interesting area of the foot and its innervation patterns for sure.
Right. And I believe even in let's say an avulsion fracture of the fifth metatarsal base, sometimes those don't even need operation. However, during callus formation, the nerve can become engulfed in that callus formation during that repair, and it may be a sign or they may present with nerve irritation symptoms, even though it was just purely an avulsion fracture and they never needed surgery. But I think that you just have to be mindful of it.
See, that's a good point. Now, let's think about this for a second, because they have a demonstrative fracture. The surgeon repairs it perfectly. Anatomical reduction, good intramedullary screw placement. Everything's nice compression. And the patient heals from an osseous standpoint, but 6 months down the line, they still have pain in that area. Well, the default would be, you would think, well, is there a delayed union? Is something, you would assign that pain generation to maybe something going on with the osseous problem, when in fact it's a nerve issue. And this is also, it's important to think about this in an ankle inversion sprain. All right. And a lot of patients that we've seen over the last 20 years, since I've really been focused on peripheral nerve, they may have had a lateral ankle stabilization. They may have had an ankle sprain without a stabilization procedure, and they still have pain way down the line. Oh, well, why is that? It's not because of the ligament. It's because the nerve was tweaked in that episode that hurt the ligament, which ultimately healed, but yet the patient still continued to go down the path. That's why you have to kind of put your nerve goggles on with these things. And everything's not osseous. Everything is, obviously everything's not nerve either. So you have to really have a more of a 360 perspective on it. So. Correct.
And you mentioning that point that everything's not osseous. I know that there is an anatomical variation of the sural nerve. Dr. Dell has mentioned it in his functional anatomy book, that 25% of people can have the sural nerve go into the sinus tarsi.
Right.
So you can automatically assume that it could be from arthritis or sinus tarsitis, but where is that stemming from?
Right.
You have to be on the lookout for that.
Yeah, Dr. Dellon and I published a paper on chronic sinus tarsi syndrome, where we actually denervated the deep peroneal nerve, or we would actually do an interfascicular dissection and then take out the two lateral fascicles to the sinus tarsi. And I think we had about 11 or 13 patients. I'd have to go back. It's been a long time since I've looked at that paper. But there were a couple that didn't get better that we ended up going back, and it turned out that they had a contribution from the sural nerve. And it depends. One anatomy book may say 15% of the time, another may say 25, 30% of the time. And that's why you have to be careful with your diagnostic blocks. And if you just give a block in the sinus tarsi, again, it's like we just talked about. It doesn't give you the definitive diagnosis if you would have come up proximally, right? If you would have taken out and blocked that deep peroneal nerve up in the anterior compartment in their lower 1/3 of their leg, and they still had some sinus tarsitis, then the next move would be to go and block the sural, and then their pain should go away. If Absolutely. It doesn't, then you have to scratch your head. But no, that's a good point. And I think the other thing that since it's a little tangential, but that's okay. That's the whole point of these things. I remember when Dr. Dellon was telling me that his thesis was that sinus tarsitis was really a bunch of neuromata. I'm thinking, what? I mean, that sounds totally crazy to me. But he said, no, think about it. You've got all these tiny little nerve branches in that canal. You have a bad inversion injury. Undoubtedly, little things get torn. Some of the ligamentous structures may be torn, and then subsequent refibrosis, those types of things could easily scar down those little branches.
Absolutely. And I'm so glad that you had a chance to publish that paper and kind of put that in the literature, because we don't often I think, nerve pathology is not the first thing on someone's mind when they're looking at a lot of these joints and osseous structures.
Right.
So it's really good that you kind of started that way back then. And as time goes on, we can learn to perfect our diagnostic abilities based on.
Yeah. We might need to do a case study on just sinus tarsitis. That might be a good one. All right. Well, any more on this case?
That's about it on this case. And
so
if you want to tell her.
Yeah. So let's give the outcome.
Yes.
So the patient did extremely well. All of the pain resolved very quickly. In fact, the patient knew within a matter of days that the problem had been addressed. That was very good. And, we were happy about that. Now, since this case, we have started to see a little, more of this. What do they say? The eyes can't see what the mind doesn't know. And now you have to start thinking about this. But I would say we probably have another 4 or 5 of these. So, people talk about the sural nerve has no known anatomical site of entrapment. I'm not sure that's correct. I think it might be correct to say the sural nerve has no routinely seen anatomical entrapment.
Yes.
Because we do see them all the time. So anyhow, that was a great case. Thanks for coming up and doing that. And what should be our next one?
Let's see. I agree with you. Sinus tarsitis, because I believe we've done radiofrequency ablation for that. And I know that'd be a great topic for our listeners to understand and learn more about.
I think that's a good suggestion. So again, if you are just listening to this on audio, I would recommend that you go see the video, because the pictures are worth, 10,000 words or 1,000 words? I don't know. I can never figure out what it is. But these are beautiful photos, and I think it just will give you a little bit of maybe a warning flag when you see somebody that comes in with a styloid process fracture. I mean, to sum it up, as with anything, you want great HPI with these patients. Larry Harkless said to me when I was very young in my career, he said, if you just shut up and listen to the patient, they'll tell you the problem. And man, he was really correct on that. And, that's so apropos to when you take care of these complex nerve patients. We spend more time sometimes on HPI than even exam. But so I think the take-home message here is it's not always peroneus brevis insertional tendinopathy. Notice I didn't use the word tendinitis. Yes. People want to read about tendinopathy versus tendinitis. I would recommend anybody read a lot of Nick Mafuli's stuff. But, so it's not always tendinopathy. If it doesn't get better after you've addressed it, you might want to start thinking about nerve. And I think that's a great case illustration, gives people a lot of power. It's a powerful little nugget. And I thank you for coming up here today and sharing that with me.
I just want to thank you for having me up here. And I want to thank you for having me a part of the fellowship program. And I just want to say I'm always learning constantly every day. And I'm so thankful to be learning from you. So,
you're very kind. Yeah, she had to say that, though, because she still has another, significant period of time for her fellowship. But you'll be a rock star up in the Northeast. I'm excited for you.
Thank you.
All right. Well, thanks. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.